ಅವರು ಇಂದು ನಮಗೆಲ್ಲ ಹಿಮೋಫಿಲಿಯಾ ಕುರಿತು ಉಪನ್ಯಾಸವನ್ನು ನೀಡಲಿರುವರು. ಪದ್ಮಶ್ರೀ ಪುರಸ್ಕೃತರು, ಆತ್ಮೀಯ ಸ್ನೇಹಿತರು, ಸ್ವತಃ ಹಿಮೋಫಿಲಿಯಾ ಅನುಭವಿಸಿದ ಅನುಭವಿಗಳು. ಅವರು ತಮ್ಮ ಅನುಭವಗಳನ್ನು ತಮ್ಮೆಲ್ಲರ ಜೊತೆಗೆ ಹಂಚಿಕೊಳ್ಳಲಿದ್ದಾರೆ. ಎಲ್ಲ ಮಾಜಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರುಗಳಿಗೂ, IMA KSP CGPಯ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಮಹೇಶ್ ಜಿ ಅವರಿಗೂ, ವೆಬಿನಾರ್ದಲ್ಲಿ ಪಾಲ್ಗೊಂಡಿರುವ ತಮ್ಮೆಲ್ಲರಿಗೂ ಸ್ವಾಗತ, ಸುಸ್ವಾಗತ. ಈಗ ಮಹೇಶ್ ಜಿ ಅವರು IMA ಪ್ರೇಯರ್ ಮತ್ತು ಫ್ಲಾಗ್ ಸಲ್ಯೂಟೇಷನ್ ಕಾರ್ಯಕ್ರಮ ನೆರವೇರಿಸಲು ವಿನಂತಿ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you. And flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength. Its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Thank you. I request Dr. Lalita HS to give introduction about Dr. Suresh Hanagawadi sir.
Thank you, Dr. Mahesh. And it is my honor and pleasure to introduce today's speaker, Dr. Suresh Hanagawadi, Padma Shri Awardee 2026, to deliver his talk on diagnosis and management of hemophilia. He did his MBBS in 88 from JJM Medical College, Mysore, and post-graduation MD Pathology 1993 from KMC Hubli, Karnataka University. Currently is professor in the Department of Pathology, Hematology Section, JJM Medical College, Davangere. He is also founder and president of Karnataka Hemophilia Society, Davangere, and involved in developing hemophilia care services. He is also former president, Hemophilia Federation of the country. And he has served in various capacities. He has total number of years of experience of 33 years so far. And he's also involved in research as a principal investigator, inhibitor development in previously untreated patients or minimally blood component treated patients. Also, hemophilia mutation studies among hematologically proven hemophiliacs, their siblings, parents, and their close relatives, and many more. He also has various publications on hemophilia mainly. Total of about 16 original publications. He's also into advisor in various advisory boards, mainly member technical committee, state blood cell, NHM, Department of Health and Welfare Services, Government of Karnataka, and also member commissioner empowerment of people with disabilities, Government of Karnataka. He has various awards and recognition. Notable among are Padma Shri Award in 2026 was honored as fourth highest civilian award of Republic India in recognition of his extraordinary contribution to medicine, hemophilia care, public health advocacy, institution building, and lifelong service to persons with bleeding disorders in India. Other notable awards, Shritej Divyagnan in 2024, an invitation from Rashtrapati Bhavan in 2025, IMA KSP Doctors Day Vaidya Chetana Award in 2026, MR Parthasarathi AV Ram Prasad Oration Lecture, and various other awards. And he is also speaker and orator in various national and international conferences so far. And he is a postgraduate teacher, also hands-on training for clinicians and on diagnosis and management of hemophilia program, capacity building program director. And he has developed various guidelines and consensus statements, mainly on hemophilia in the country. Also, he has held many important positions in national, state, and regional organizations. So I request him to deliver his lecture on diagnosis and management of hemophilia. Dr. Suresh Hanagwadi.
Thank you, Dr. Lalita, for this introduction.
Thank you,
So,
sir.
I am really honored and happy to accept this lecture organized by IMA State uh, Branch and Dr. President Dr. Veerbhadraya and Dr. Suriraj, Dr. Uh, Kalakonta sir and Mahesh. And when I came to Tumkur for your program, and Dr. Mahesh requested me to take up this webinar. And in general, any these kind of opportunities, I don't say no, because hemophilia being a low volume, high cost disorder, having low level of awareness, it is an opportunity for me to orient, create awareness, update the management of hemophilia among our medical community. And today, I will talk about the basic aspects. I will not go into the too much of the details. So just the approach to patients with the bleeding disorder, not only hemophilia, but the management of hemophilia, evolutionary treatment products, and I will conclude, and later anybody can ask questions. And before going into our today's topic, so all of you are aware how bleeding stops normally. There are four pillars of normal hemostasis, that is a vascular phase, the blood vessels, endothelium, and platelets which rush when there is an endothelial injury and form a primary hemostatic plug. But this primary hemostatic plug formed because of vasoconstriction and platelet activation. So we call primary hemostasis plug. But unfortunately, primary hemostasis plug form is a friable mass. It can be peeled off easily. Even the flow of the blood in the major vessel will detach this platelet plug. That's why the next phase is very crucial, that is coagulation phase. These 13 plus 4, 5 clotting proteins, they act in a cascade and ultimately culminating in the formation of a sticky substance we call fibrin. And the primary hemostatic plug and plus this clotting mechanism ultimately stops the bleeding. But there is one more component, last one, that is we call fibrinolytic phase. The first three phase defects can cause bleeding, whereas the fibrinolytic phase, that is once the purpose is served, it has to be dissolved. It has to be, the clot has to be cleared. Like otherwise, thromboembolism can occur. There are certain hematological disorder causing deficiency of these protein leading to thrombophilia. So whereas today we are talking about hemophilia, but the fibrinolytic pathway defect can lead to thrombophilia, thromboembolism. Now let us see how to approach to a patient with suspected bleeding disorder, suspected bleeding. So here, as all of you are aware, the history taking is very, very important, and examination of the patient, appreciating certain physical examination or lesions to appreciate. And of course, with this, nearly 80% of the diagnosis we can make. But anyhow, we need laboratory also to final or to diagnose for the final diagnosis and for the sake of treatment. So let us see what are the important points while taking history. As I told you, it is very, very important. So the age of onset itself is an important point. The bleeding disorder occurs during birth. Bleeding disorders occurs during childhood and later adulthood and even the elderly. The different disorders are there. Is because the disorder which occurs immediately after the birth, for example, umbilical stump bleed, we have to suspect, once you rule out vitamin K deficiency, we have to suspect factor 13 deficiency or A fibrinogenemia. So, childhood, because hemophilia patients will not bleed during birth, but as the age, like childhood, when they start walking, crawling, and they get hurt, then they have bleeding episodes, maybe in the musculoskeletal system. Whereas the late onset bleeding is not, because to understand, make you understand, most of the bleeding disorders in the early life, they are all inherited bleeding disorders. Whereas the late onset, after 50, 60, even 70, then it is not inherited, they are all acquired bleeding disorder. Nowadays, we talk more about this acquired hemophilia or even autoimmune pathology in causing destruction of the clotting protein. Okay, and also in addition to the age, type of bleeding will tell you the cause. The most of the superficial bleeding, most of the primary, they point towards primary hemostasis, whereas the deep-seated bleed, like hematoma, like joint hemorrhage, will help you to make the diagnosis of secondary hemostasis disorder. By noting the type of bleeding itself, we can make up our mind for further. The another thing is profuse bleeding. Profuse bleeding, again, it is more of platelet disorder or primary hemostasis disorder. Whereas a typical secondary hemostasis, we call slow, prolonged, sustained bleeding. It is very typical, slow, prolonged. Patient feels the bleeding has stopped, but again he will rebleed. So that is because in these patients, for example, hemophilia, the primary hemostasis is absolutely normal. Platelet plug can be formed, but its sustenance cannot happen because of the lack of the clotting proteins. So that's why it is a very typical, slow, prolonged, sustained bleeding points towards coagulation disorder. So as I told you, birth history already I have discussed, and past history, yes, find out is there any similar bleeding episode in the past or repeated bleeding episodes itself will suggest the inherited nature of the disorder. Then this is very, very important. Post-surgery bleed. Post-surgery, if the child gives the history of prolonged bleeding after circumcision or tooth extraction, then we have to suspect bleeding disorder, because the especially mild to moderate bleeding disorder can be suspected. And treatment history also you note down. So the what is the how the previous bleeding episodes were treated, whether it is transfusion of blood, whether it is FFP, cryo, or any factor concentrate, that itself will tell you it is inherited bleeding disorder. And drug history is very, very crucial, especially aspirin. Aspirin interferes with the function of platelets, that history. But especially when you plan investigation, we should take all this history. Those patients who are on aspirin because of the IHD, yeah, if you don't take this history And if you do investigation, all investigations will be erroneous and you will be misled. So that's why aspirin intake or anticoagulation history should be there. If patient is on that, you should document, and especially aspirin, at least ask him to stop taking for at least 1 week, then you can plan for investigations. Then in females, menstrual history, especially puberty menorrhagia. The most nearly I would like to share that 5% of puberty menorrhagia patients, women, have Van Willebrand's disease. So that's why these are all the, and also you should know, that is family history has to be taken. Family history is better to write a family pedigree to know the mode of inheritance, and you note down whether they are married consanguineously or not, and you take the history with the couple or the mother who has got a series of pregnancy loss, especially for our gynecologist. They should think fibrinogen deficiency or even factor 13 deficiency for a series of pregnancy loss. If that is there, you document and suspect, and you can evaluate for further investigation. Then past history, yes, the drug history I have already mentioned. And coming to some examination, look at the patient. Okay, so if the lesions are there, depending upon these lesions, you can think of the underlying pathology. For example, petechial hemorrhages, the 2 millimeter, and purpuric lesions, 2 millimeter to 1 centimeter, and ecchymosis, very bigger one, more than 1 centimeter. They are all due to you can call mucocutaneous bleed or superficial bleed. They are all because of the primary hemostatic disorder. And the secondary hemostasis disorder is very typical, as I told you, slow, prolonged, sustained bleeding, and more typical is internal bleeding. Internal bleeding into deeper structures like joints, muscles, even brain. So iliopsoas muscle bleed. So these are the typical bleeding manifestations of coagulation disorder. Now with some lab investigation. Now actually with this history, automatically you will develop an approach to the diagnosis of hemophilia or any bleeding disorder by asking certain investigation. In general, what are the investigation you are going to ask? Simple investigations like CBC everywhere is available. Under this complete hemogram, the most important investigation to look at is platelet count and even morphology in the peripheral smear, whether they are discrete, whether they are in clump in nature, to rule out functional platelet disorder. And bleeding time, still I have put, but I have not put here clotting time. Always be aware, careful, that clotting time is a useless test, and in fact it will mislead. Okay, clotting time may be normal in mild to moderate hemophilia. Believing this, our surgeons will take the patient for surgery. On OT table, bleeding will never stop. So that's why don't believe clotting time. Or I always tell our postgraduate, BTCT concept we should discourage, and ideal is if clotting time is prolonged, you accept it, but normal clotting time don't accept. It will not rule out milder bleeding disorders like mild hemophilia A or B. Okay, then we need to ask for plasma clotting test. Each test will tell you the integrity of the coagulation pathway. If extrinsic pathway, it is reflected in prothrombin time. If it is intrinsic pathway, reflected in APTT, common pathway. Like so, these three plasma clotting test will open the door for further evaluation. Okay, and another factor 13 screening test that can be done in any average laboratory. And if platelet count is normal and everything is normal, patient still bleed, gum bleed, and all those, you have to suspect. With normal platelet count, if platelets are seen in discrete in the peripheral smear, you have to suspect Glanzmann's thrombasthenia, where function of the platelet is affected. And again, correction studies, whichever the plasma clotting test is prolonged, try to correct it by adding normal control plasma. If it is corrected, then it is coagulation disorder. Suppose if it is not corrected, definitely you are not dealing with a coagulation disorder. That time you have to suspect the lupus anticoagulant, that is inhibitor, natural occurring inhibitors. Okay, the further correction studies and factor assay we can do, and nowadays the factor is available all over the state in all district hospital. Our patients receive treatment repeatedly and they develop inhibitors, that is antibodies against the factor 8 they receive. So that's why inhibitor screening test also has to be done as a routine in a hemophilia patients, and test for fibrinolysis and family studies beyond the scope, and especially molecular studies. But anyhow, remember this thing, as I already discussed, while fixing the investigation, while sending the patient to the lab, please keep it in mind whether they are on aspirin or not. Please take the history whether they are on receiving any anticoagulants, or any patient you want to plan for investigation. If he has received blood and blood components or factor concentrates, and you cannot take for investigation at least for the next 3 months. Okay, otherwise it is not reliable, because whatever the blood transfusion you have done, it comes in the way of the coagulation and give erroneous report. Again, as I told you, anticoagulants and all those. So one more very important, again, I will not go into the details of the lab, but this is very, very crucial, because most of our doctors, they do not send sample or select sample properly. Please remember 3.2% sodium citrate is the anticoagulant for all coagulation studies, and it has to be maintained in 1:9 proportion. If you do not follow this, your results will be erroneous. And you are dealing with various clotting protein, and each protein has got a fixed half-life. Okay, they are all protein in nature. You should do investigation as early as possible. This aspect I will skip because that is meant for our lab pathologists. Now, with this background, let us take up what exactly hemophilia. So, hemophilia, I told, it is a congenital bleeding disorder due to deficiency of certain clotting protein, but most common, nearly 80 to 85%, it is factor 8 and followed by factor 9, which is known as Christmas disease, and very, very rarely hemophilia C, that is due to factor 11 deficiency and very mild bleeding disorder. But most important, these two, that is factor 8 and factor 9. So in our country, the demographic wise, what is the incidence of hemophilia? For every 10,000 general population, we have one hemophilic. Since it occurs predominantly among males, we can say for every 5,000 male births, we have one hemophilic. According to this, in the world, there are about 1 lakh or 4 lakh hemophilia patients. Among these, out of this, 25% of them are in our country. Nearly 80,000 to 1 lakh hemophilia patients are in India itself. So now, with the help of our federation chapters, now it is changed, around 28,000 patients are identified. Coming to Karnataka, there are about 6,000 to 6,500 patients, but identified are 2,800 patients. So severity wise also we can classify depending upon the factor level. Those patients who doesn't have factor at all, we call severe. And this category is the one who have spontaneous bleed and repeated bleed. Okay, whereas moderate category 1 to 5%, they don't have spontaneous bleeds are uncommon, but traumatic bleed definitely they suffer. Whereas mild category, this is according to me dangerous category. They may not have any manifestations, and when you take up for surgery, then they don't, bleeding doesn't stop, or any major accident, bleeding doesn't stop. So that's why the mild category, That's why I am insisting to screen for pre-operative screening test should be PT-APTT, not BT-CT. And as you know, this is a genetic disorder. Genetic disorder, there are 23 pairs of chromosomes, one pair is sex chromosome, and it is X-linked recessive disorder. The gene which is responsible to produce this clotting protein is located on X chromosome. So that's why the males are sufferers and females are carrier. That doesn't mean all women in the family need not be carriers. Okay, we have to do the test and label them whether they are carriers or not. Okay, so that's why the males are sufferer. Females, they have we call carrier. Carrier, these are the people who are affected very badly. On one side, psychosocial aspects and guilt of having given birth to an hemophilic son. So they suffer a lot of psychosocial issue. That's why I always tell, we hemophilics suffer physically, whereas our mothers suffer psychologically. They need proper counseling. And clinical manifestation, this already highlighted the typical nature of bleeding in hemophilia, slow, prolonged, sustained bleeding, and deep-seated bleeding. You can see here the bleeding has started, joint. Synovium is highly vascularized tissue. Even any jerk or any spurt in the capillary, that can lead to bleed, and since it is inherited and it go on collecting till the joint is affected. Okay, so sorry, 1 second. Yeah. So this is a typical acute hemarthrosis in hemophilia, and also they can bleed in any part of the body. The most common is musculoskeletal, but they can bleed in muscle. You can see here iliopsoas muscle, very big muscle, very dangerous bleed if you don't treat immediately. Even recently, just 2 days back, we had one patient with retroperitoneum. Started with iliopsoas and it extended as retroperitoneal bleed and life-threatening bleed, and we have to put lot of efforts by replacement therapy. And also I would like to highlight this slide because most of our hemophilics, they have certain bleed which should be given immediate attention. For example, they bleed in the flexor group of the muscle, that can lead to Workman's ischemic contracture. We should never wait, or we should never waste time. Immediately you replace the factor. And even foot drop. Okay. And also because of the iliopsoas muscle bleed. Okay. The life-threatening bleed, CNS bleed, laryngeal bleed, and gastrointestinal bleed. This bleed is very bad because it can lose, a large amount of blood may be lost, and patient may come in a shock. And genitourinary bleed, hematuria, and this one. And life-threatening bleed, as I told you, CNS bleed, and yeah. So the lab investigation I have already mentioned little detail later, and you can see these are the investigation. I will not go into the detail. APTT, isolated prolongation of APTT, and it is corrected by mixing study. Okay, corrected, and you do factor assay, that is lower. And also, as I told you, inhibitors, which I will tell later, the negative or positive. And also nowadays, even molecular studies we can do, type of mutation they are having and for the cause of hemophilia. So management of hemophilia, all of you are aware, it is the replacement therapy is the mainstay in the management. Whatever they lack protein in the blood, that has to be replaced. That is available through human blood, a pool of plasma extracted, we call anti-hemophilic factor derived from the plasma. But because of the risks associated, if one donor is HIV positive, that too a window period, the whole product will be contaminated. So that's why the Western world started this recombinant factor. But anyhow, thanks to the growing technology, even the plasma derived factor can be made safer by viral inactivation method. For example, simple heat. HIV is heat labile virus. It can be killed instantaneously. Okay, so that's why I promote the antihemophilic factors, whether it is plasma or the recombinant, because they are free from all these infections. So okay, so the instead of wet blood products like cryo and FFP and all those. So this is an evolutionary. It started with the blood, then we came to know that it is in the factor 8 is rich in cryoprecipitate. Then like this, it is there is a evolutionary phase. It is a ever challenging situation every time. For example, when HIV the threat came, then viral inactivation came. So then the another thing I was mentioning, half life of the factor. Factor 8 has got 8 to 10 hours, whereas factor 9 has got the 20 to 24 hours. But now the technology have come to enhance these factor of life and make it available, the frequency of infusion, everything. But nowadays, recently, there is one more wonderful development we call rebalancing therapies, which I will tell later. Okay, so whole world, we have two modality of treatment: episodic treatment and prophylactic treatment. Episodic means whenever they sense the bleeding, you have to immediately replace the factor. Whereas prophylaxis is the one, whether bleed is there or not, periodically you infuse factor, weekly 3 injections in case of factor 8, weekly 2 injection in case of factor 9. Whereas this is already followed in Western world. That's why the prophylaxis is the gold standard treatment, because it will never cause bleeding, and no bleeding, no disability. So just little bit about, as I told you, half-life of the factor, and also this is very important for while calculating the dosage. 1 unit of factor 8 raises 2% of hemostatic activity, whereas factor 9 is little longer, that is only 1 unit increases 1% only. So this point we have to keep in mind while calculating the dosage of the factor. And as I told you, prophylactic treatment is the gold standard treatment as per our World Federation of Hemophilia. Actually, in our country, yes, government, we should be thankful to government for procuring these medicines are available. But what has happened? Episodic treatment, we utterly failed in preventing disability. We treat bleed, whereas in Western country, they don't allow their children to bleed. That is possible only by prophylaxis. Okay. Yeah. So as I told you, extended off-life factor, the fact with various technology, the 8 to 10 hours is made 36 hours or even more than that, so that the frequency of, I told weekly 3 injection. Now it has come to weekly 1 or even once in 15 days. So like that extended half-life factor has improved the quality of treatment. So these are extended half-life factor. As I told you, we call pegylation, FC fusion, albumin fusion, whatever you can see, the half-life is enhanced. 1.5 times longer, 5 times longer in factor 9. Okay, so little bit about inhibitor development. Inhibitor development, as I told you, 20 to 30% of our hemophilics on receiving regular transfusion, they develop antibodies against the factor 8 they receive, and factor 8 becomes ineffective. This is most common with the factor 8 patient, whereas the factor 9 patients, it is less 2 to 3%. And when life saving medicine becomes totally ineffective, just imagine how to manage, how to stop these patients, stop bleeding in these patients. That is only, yes, whenever you treat patient with hemophilia, so these are, when do you suspect inhibitor? How do you suspect inhibitor? Yeah, he is receiving factor 8. This time, sir, somehow I am not feeling comfortable. The bleeding has not resolved. Pain has not has come down. Poor clinical response. Suspect inhibitor. Okay. In the laboratory, we can do screening test. screening test, that is APTT and 2-hour incubated mix. If it is not corrected, then patient has got inhibitor and it has to be corrected. Okay, so once the screening test becomes positive, the next thing is to know whether they are high titer inhibitor or low titer inhibitor. So this is again a complicated, complex test which we need to do that and categorize patient who are more than 5 Bethesda unit, who are less than 5 Bethesda unit. Why this categorization? Because less than 5 Bethesda unit still factor 8 work. Still you can consider factor 8 in the treatment. Only modification you have to do, you have to double the dosage. Okay, whereas those patients who are having more than 5 Bethesda unit, any doubling, any tripling will not help. Factor 8 absolutely doesn't have a role in high titer inhibitors. So then how to treat these patients? We call them bypassing agents. Okay, bypassing, the most two common bypassing agents available in our hospital, that is activated prothrombin complex, APCC. Now it is available as FIBA, and recombinant factor 7. SNOVO 7. Right now, as in the beginning I was telling, there is one girl fighting with life and death with factor 7 deficiency. We are trying our level best to arrange factor 7 in Gulbarga, Jim's Medical College. Then how to, whether this once patient develops inhibitor, is it possible for us to eradicate? Yes, it is possible. Again, we call it as an immune tolerance induction. Immune tolerance induction, small quantity of factor. Otherwise, to tell very briefly, to train the body to accept this factor. Okay, that I will not go into the details. Then the recent technology has resulted in a wonderful medicines we call rebalancing hemostasis. To make you understand, the hemostasis is a balanced process. On one pawn, there are 13 clotting protein we call procoagulants. On another pawn, there are the thrombin producing factors, that is antithrombin 3, tissue, the plasminogen inhibitor, and protein C, protein S. Okay, so this is, as long as the balance is there, there is no bleed. Normally these, it is a balanced process. What happens in hemophilia? There is deficiency of one clotting protein. For example, factor 8 is not there. All these years, how we have treated? We have given replacement of factor therapy. Okay, now you need not bother about this deficiency. You look at other pawn where these that is thrombin producing factors, you either reduce or knock down one. So you can see here rebalancing. That means you remove antithrombin on other pawn, and that's how hemostasis is balanced. And balanced hemostasis is zero bleed. Zero bleed means no disability, so that quality of life is improved. Our children can go to schools regularly and achieve good education. I always tell my blood brothers, we lack only clotting protein in the blood, nothing else. We are equally competent. We have capacity, we have skills. Only government, society, all of us has to make a conducive atmosphere. This is the drug which has already, now I am very proud to share with you, this medicine is made available all over the state. In all district hospital, our children are receiving, and so that they are prevented from becoming disabled. For factor 9, there is still, it has not yet come, it is on the way. Fitusiran we call factor 9. Okay, then emicizumab, there is a particular dosage that we give. I will, yeah, this that is known as emicizumab, and hemlibra we call. There is a protocol, and this thing we can give. And but there are some certain challenges after putting patients on emicizumab. What are these? That if actually hemlibra or emicizumab is not given to treat the bleed, it prevents the bleed, but they can also bleed we call breakthrough bleed if there is any major injury or any any surgeries. That time we have to go for factor replacement therapy, but low dosage factor 8. Okay, or this thing. And this is how the treatment protocol. And also the laboratory, we cannot do the for simple plasma clotting method. We have to go for chromogenic method. Now, yes, this one, care to cure. We are moving from care to cure. That means eliminating the disorder by gene therapy. Now it is successful in CMC. There are successful trial studies, and what is a simple technology technique I can tell you. The place factor 8 are transgene, that is AAV adenovirus vector, and place this, and they go to liver hepatocytes, and hepatocytes start producing this factor 8. Again, I will not go into the details. And the hepatocytes, they produce almost, the curing the patient. Let us hope, but anyhow, there are some more challenges, the sustainability of the raised factor level and all those, and we have to wait. But it is almost in the nearer to cure. Okay, and prevention of hemophilia also is important, because the carrier, as I told you, all women in the family of hemophilia need not be carriers. That's why carrier detection test has to be done. And if she is found carrier, nothing to worry. We can offer her prenatal diagnosis at amniocentesis technique. We can detect whether the growing fetus is having hemophilia or not. If hemophilic fetus, then legally they are eligible for medical termination of pregnancy. So that's why carrier detection and prenatal diagnosis, that has to, we have to counsel and help support the families. Again, as a, you have to educate, encourage them, physical activity, physiotherapy, and especially avoid platelet interfering drug like aspirin. Okay, you simple paracetamol is more than enough, and regular exercise, physiotherapy, regular dental care, so that good oral hygiene will prevent caries tooth. So all this education in our society, we do conduct camps and educate the parents and pay adolescent boys about their care. And last, yes, to conclude, I would like to share, there is many people think that it is a new disorder. It is not new disorder. It is even from history of page, in the 5th century, there is a mention of hemophilia in the Bible. So what is that interesting story, that is that a woman's third son is exempted from circumcision because his two elder brothers died after circumcision. This woman, first child circumcision dies, second child circumcision dies, and third pregnancy, she is terribly worried. And in the community, they are not allowed, that is mandatory circumcision. Then she has to plead the king, King Rabbi Judah, and to exempt her third son, otherwise he will also die. And Rabbi Judah will pass one resolution that this woman's third son will be exempted from circumcision. And also, all of you are aware, it is known as royal family disease. That means we are not royals, just because it plagued the famous royal family, England. Queen Victoria was a carrier and a grand carrier, and our princes were married neighboring royal kingdom princes, and that's how the European kingdom was full of princes with hemophilia and princess carriers. So that's how you can see here one photograph I have put is Prince Alexis. You just see how he is standing. How he is standing. How he is standing. You can see he is avoiding weight on the knee because of the bleed. Okay, the royal. But we call it as, what we call this pose, royal pose. This boy, princess royal pose. So they suffered a lot, But anyhow, nowadays it is eliminated from their family. So in conclusion, yes, hemophilia therapy is rapidly evolving, as I have mentioned, from blood to even gene therapy, and factor replacement is still the mainstay right now, but non-factor therapy has brought lot of confidence among the mothers, among the children, where we can achieve zero bleed, and our children can go to school. Absenteeism is a major problem in our families, and now our children can go to school and get good education, and they can become productive citizens in this country. Yes, gene therapy is right around the corner, and anytime we are we are hoping of getting this therapy. And so this is nearly since 40 years I have been advocating for the quality of care for my blood brothers, and only during this time it was very difficult for those days when government was not involved in caring, and it is because of Dr. S.P. Balasubramaniam, who gave free concerts without collecting even 1 rupee. He helped us in raising funds, and we could collect substantial amount and brought factors from the market and made it available to our blood brothers. Tried our level best. But anyhow, I remember, and one philanthropic woman donated a piece of land, that is CA site, and that's how we could establish all the facilities under one roof, from inpatient facilities there, physiotherapy is there, hydrotherapy is there, and even the counseling, everything. Even blood bank also we have established, Lifeline Blood Bank. That is because many people ask why blood bank is needed. Because we don't promote wet blood products. But dear friends, I will tell you, there are certain rare bleeding clotting factor deficiency like factor 13. Factor 13, nowhere in the world, no European market factor 13 concentrate is coming. But anyhow, it is beyond the reach of common man, and we have to go for cryo, FFP, platelet concentrate for Klangmans. So that's why we have to establish blood bank. And our board has taken a very cautious decision. Not only we are providing free treatment services to hemophilia, any number of units of blood and blood components to other patients we are committed to give totally free of cost. Any inherited bleeding disorder can walk inside and get these services totally free of cost. And yes, only thing is laboratory diagnosis we are not able to make free because very expensive reagents. But anyhow, some patients, selected patients, case to case basis, we make free. Otherwise, except this, even 3 meals to the admitted patients, we are giving at free of cost. I need your support, your encouragement. Any bleeding disorder patient you come across, you can refer and further lab diagnosis or further management. But nowadays, once we do final investigation, we will send back to that particular district, because district hospital can give all these factors free of cost. Okay, thank you. I once again thank Dr. Veerbhadraya, Dr. Mahesh, all the IMA colleagues for giving this opportunity. Thank you very much.
Thank you, sir.
Thank you very much, sir. Thank you very much, sir. It was very enlightening lecture. Thank you so much.
Thank you, sir. Thank you. Any questions I can? Because I tried to be very brief, and I went to only the basic. Some complex issues I avoided.
Yes, sir, it was a very wonderful lecture, short and sweet. Many might have forgotten physiology and pathology. So there was a reorientation.
Thank you.
Thank you very much, sir. Any questions from the audience? Sir, thank you very much, sir. No questions, I think.
Thank you. Thank you very much.
Thank you, sir. Thank you very much, sir.
Okay.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
I thank everyone for attending this webinar on diagnosis and management by Dr. Suresh Anagwadi, sir, a Padma Shri awardee, for his valuable talk and precious time towards IMA KSB. So I thank everyone who have attended. So thank you very much, sir.
Thank you, sir.